syndrome, whether they are completely missing an arm of the S or they have two SS, they will look pretty much like sickle cell patients. But we do know that the hemoglobin SS genotype has the most severe hemolytic anemia. And for us, for the cardiovascular complications, we do tend to see it in this group the most. Oh, let me slideshow. So it looks like you gave me, I think I need to do the admission because I see somebody in the waiting room. So I'm gonna, if it pops up, I'll let them in. And just bear with me. Let me make sure I'm in slideshow so you can see better.
Okay, please, yes, let them in. That is better. Well, we're seeing your slides and we're seeing I guess the slides in waiting.
Okay, so yeah, maybe the other way was better then.
Are you able to? I thought I admitted Genesis, but that's
Okay,
better. That's
that looks a
better.
little bit better. Okay. So in terms of the epidemiology, yeah, I think she's back in the waiting room. And so,
Okay, I just let her in.
okay, great. Um, so we know sickle cell was discovered over a century ago. The prevalence is in about 1 out of 365 African American births in the US are affected. And it also exists quite significantly in Hispanic Americans. 1 out of 16,000 or a little bit over 16,000 is the ratio there. Approximately 2,000 babies are born with sickle cell anemia in the US every year, and over 200,000 babies are born each year with sickle cell disease in Africa. So you can see the order of incidence in Africa is just so much more. Over 25 million people are affected with sickle cell disease worldwide. And this focus area is usually the sub-Saharan Africa, India, and the Mediterranean. Yeah, it still says I admit her, so I'm going to admit her again. I don't know what's going on, but hopefully she's in. So, so let's talk about the mortality rates. So 50 to 90% of children born with sickle cell disease in Africa die before the age of 5. This is just this is still just so much a reality, just because of depending on where in Africa we're talking about, the access to healthcare, right? It's going to be impacted. But in developed countries, what we have seen is as the years have gone by, the life expectancy has improved significantly over the last 60, 70 years. The last study I have referenced here is a UK study that showed like average in 2016, average survival of 67 years. Well, I can tell you, I have an 80-year-old patient in my practice who has sickle cell disease, who actually has developed a lot of the things that I'm going to talk about today in terms of heart disease, but she's still alive and she's still kicking and still very much part of life. So we know that overall, sickle cell patients are doing better. Heart disease is a major factor of sickle cell disease. And the reason for this is because the chronic progressive end organ damage that we see affects the heart significantly. And it's actually the main cause of death, affecting 20 to 32 percent of patients. Okay, so about a third really die of the heart-related complications. That's why it's so important. In autopsy data that they did a number of years ago, they saw that almost over half of them had enlarged hearts. That's what we call cardiomegaly. A good portion of them already had evidence of heart attacks, about 1 out of 5, and heart failure was already present in about 10%. Trying to advance the slides here. Hold on. Okay. So, I just that we just look at this again. I kind of hinted about that before. We know that the oxygenated red blood cell shown here on the top here, okay, when it gets deoxygenated, so the red blood cell carries the oxygen, so it has to carry it and then deliver it. So when it gets deoxygenated, that when a sickle cell patient, that makes it prone to polymerization. That means curling up really. It gets sickled in this shape that we hear about a lot. And a sickled red cell, a clump of sickled red cell, is not going to be able to move as easily through blood vessel as a normal red cell. Okay. So because of this sickling and occlusion of the vessels, especially if you think about the vessel, how it branches down to the smallest detail, smallest branches. This leads to infarction meaning occlusion and dead and can lead to tissue death. And then it also leads to hemolysis, where the red cells themselves would kind of like break apart. All that process is not just a mechanical problem, it induces an inflammatory response in the body. That inflammatory response actually makes the body clot, and it makes clot formation happen down to the smallest level of vessel in the body. That occlusion of those vessels, as you can imagine, is tied to ulcers, it's tied to pain that they get, it's tied to the spleen getting affected, the acute chest pain that they get, the kidney disease, inflammation all over the body, strokes, okay? And our topic of discussion today, pulmonary hypertension. And so we have to remember that sickle cell disease is not just, oh, you have pain because you don't have enough oxygen. It's because of this pro-inflammatory state that they're in, constantly on and off, and also the things that are released into their body when those cells, when those red cells, when they break apart. So those two mechanisms are kind of how we look at it. We look at it as a vascular occlusion, yeah, like something just clogging off, causing pain, causing chest pain, causing bone marrow infarction. But also we look at it, we remember that that hemolysis, that breaking apart of the red cells induces a vasculopathy that now can eventually lead to the vessel walls getting thickened, as they get over time. And so they develop this sort of chronic illnesses in their vasculature. That's the heart of why they get systemic hypertension, just having high blood pressure, and the hypertension that can happen in the lungs, pulmonary hypertension. And also that's linked to leg ulcers and everything else that we know that these patients would have. So what are the sequelae of sickle cell disease? There's the acuteness, the acute pain, the infection, the stuff that gets them to the ER quicker, right? The chest pain, anemia. Okay, sometimes they can even have an aplastic crisis. What that means is they almost don't have any blood. Okay, so that is a crisis. And then the organ damage that we see, an acute stroke, or maybe the spleen starts to fail, or even the kidneys sometimes can start to fail. But there's also this sort of chronicity where, yeah, we may have stabilized them in the emergency room or a few days, give them blood, oxygen, manage the pain, hydrate, yeah, and treat the infection. But just the fact that they keep going in and out of crisis, in and out of crisis, it's a constant insult on the organs. And in the two organs that we're talking about the most today, in the lungs and also the heart. Okay. So that chronic condition, actually, the impact of that is the one that we know ties so closely to increased mortality in these patients. So what is really going on in the body? You know, one may pause to think about it. You know, you're chronically anemic, chronically you don't have enough oxygen carrying capacity, right? Because of the chronic anemia that they have. So the body tries to compensate for that. So the body would, you have more plasma volume, the heart is working harder, your lungs are trying to like compensate for it. So that's the nature of the body. The body will try to compensate for what it thinks it's missing. Okay. But sometimes when the body tries to compensate for it, it overcompensates. And that overcompensation is when the heart starts to get enlarged. The heart starts to thicken. It starts to, and the heart is not supposed to be so enlarged. It's not supposed to be so thickened. So over time, with the heart working so much harder, we can see that the heart can fail and begin to have problems as well. So the body is trying to help, but in the process of helping, it's a maladaptive response. And that is what leads to the chronic problems that we can see. And so I try to draw it here for you to see. This is on the left, is a patient with SS, sickle cell disease, right? So they have the two allele, SS. And we see that, you know, the heart gets enlarged, everything, like this is the top bar, we always flip things in cardiology. So the top is actually the bottom of the heart, the ventricles, it gets enlarged, and hence it's not working like it should. Everything gets enlarged, heart is really trying to compensate. And then that enlargement also affects how pulmonary hypertension, high pressures within the lungs as it relates to the heart develops. Okay. And we can see very similar with patients who have hemoglobin SC. So their second allele is actually a C mutation, and they can have it too. Maybe not as much as the SS, like I mentioned earlier, but they can have these things. And so, what are all this in summary? What is some of this maladaptive cardiac remodeling? Just a big name for us to say, the heart is trying to fix itself, fix this situation, but it's not a good way. So, what does that lead to? They can get very chronically volume overloaded. They just have too much fluid in the body that the heart can't handle. They can get the microvasculature. So again, the vasculature not working well. And of course, they can get iron overload, right? Because you keep getting all this iron being released every time the red cell lyses, or every time they get blood and that lyses. So too much iron in the body, we know it's not good for the heart. And then they can get hypertension. That's what we call systemic arterial hypertension and kidney failure. So just to talk a little bit more, and I'm not going to dwell on this too much, and this has all been studied, okay? This is just to show they compare their hearts to normals, and they always have larger hearts, okay? Thicker hearts, okay? Like shown here, thicker heart is working harder in sickle cell patients, so thicker, larger. In cardiology, we don't want that, right? That's the road to heart failure. When the heart is too large, too thick, it's working too hard, and it's not going to be able to sustain that. Okay? We know that the more anemic they are, the bigger the heart is. That's all I'm showing here. The more anemic patients are, the bigger their hearts are. And that has been correlation over and over again. So the severity of the left ventricular dilatation is closely linked to how anemic they are. And I pretty much made a lot of these points, but just down on the bottom in the red, I'm showing you that, yeah, so the heart gets thicker and thicker. So, but because the heart is getting thicker and thicker, something forms that you're going to hear me talk about called diastolic dysfunction. So diastolic dysfunction is a term that we use where to the untrained eye, when they look at their heart, when they're still kind of up and about, it looks like it's a normal heart, but it's not a normal heart because the way the heart is receiving blood and the way it's getting blood out of it, it's not normal. And that syndrome in cardiology is called diastolic dysfunction. So these are the patients that can get short of breath. They don't feel as good because the heart is always working harder than it needs to. And because of that, the heart doesn't feel well. It feel, not feel. Okay, that's the African accent. It doesn't feel well and it doesn't let go of blood well. Okay. So I talked to you, I just did number one, that's the chronic volume overload, okay, right? Chronically, just have too much fluid in their body because the heart is working too hard. And then we can talk about the microvascular dysfunction, okay? That's what I was talking about earlier, about the fact that, because the red cells keep lysing and breaking up, that it induces an inflammatory process. And something called nitric oxide is depleted in these patients. And when nitric oxide is depleted, it causes damage to what we call the endothelium. That's the vasculature to its smallest entity. Okay. When that happens, it doesn't matter what disease condition gets you to this place. The same thing happens. The heart thickens, the heart becomes fibrotic, okay, like almost like scarred over, okay? And that worsens that diastolic dysfunction that I was talking about, where the heart is not able to work as efficiently as it needs to. And this is just to show you that this has been correlated many times in research. In this situation, I think this was the MRI study where they looked and they proved that, yeah, these patients definitely have more diffuse myocardial fibrosis than normals, okay? The heart gets more fibrotic over time. And this is shown in this image, showing that they have this thin layer that doesn't belong there because of, again, there's damage going on to the heart muscle and to the vasculature. We talked about the iron overload, which I'm sure a lot of, if you're around sickle cell patients, you know about the iron overload. Sometimes they have to give them medicines to get rid of iron from their body because iron is an element, okay? And your red cells carry it. But if they keep breaking apart, you keep dumping iron into your organs, and that affects how the heart work. But surprisingly enough, iron cardiomyopathy is not that commonly seen in sickle cell patients. We don't understand why. You would think that you'll see a lot of it. It exists. I have patients who've had it, but it's not, you would think, oh, all of them are going to have this because they're always, anemic. They're always lysine, but for some reason they're protected. We don't see it as much in the heart, but we can see it in the liver. That's where we see it. Okay, and the last kind of maladaptive cardiac remodeling that I want to mention is about the fact that people forget they could be 20, 30-year-old sickle cell patient, but they got hypertension. And the hypertension can come earlier because of all this stuff that they're unique. They have other things going on in their body than your regular 20-year-old. So they can develop hypertension and certainly kidney disease at a very young age. So normally blood pressure of sickle cell patients is lower than most people, but they have increased risk of strokes, the diastolic dysfunction that I mentioned, and death in sickle cell patients who have higher blood pressure. Even when they can have blood pressures of 130 over 80, for them, that's too much. So I tend to treat them. I tend to recommend treating their hypertension even when it's not whooping high. I don't wait till they're like 150, 160. We want to keep their blood pressure lower because they already have a lot of insult going on to their organs. So the slightest insult can be something that can tip them over. Okay, so we want to treat that. So you might see us put them on blood pressure medications at a lower threshold than what we might do in a 40, 50, 60-year-old. Okay, renal failure is very common. A third of sickle cell adults have some level of renal failure, and we know once they develop renal failure, there's higher mortality. So you have this vicious cycle of cardiac disease and kidney disease, cardiac disease and kidney disease in these patients. Okay. So I've already mentioned a lot of this. I'm not going to belabor the point, but just to kind of put it all in front of you that when I am looking at a patient with sickle cell patient, I'm looking for signs of any of this entity. So they can have heart failure, like I just mentioned, which is all kind of related to the diastolic dysfunction. They can just have more of a pulmonary hypertension. Like my 80-year-old patient has pulmonary hypertension for sure. And so they're chronically on oxygen. At this point, she can't get off her oxygen 24/7. She just would literally not wake up. Okay. And then they can have arrhythmias. Okay. That's one that nobody talks a lot about. Because their heart is not normal, they can actually, the electrical connections of their heart becomes abnormal. Okay. And so they can have all kinds of arrhythmias. So we tend to want to be very aware of that and screen them early. Any symptom that sound like it, we want to screen them and make sure that that's not what's happening. And unfortunately, they can just present suddenly, like sudden death. Okay. Just, people dying in their sleep. Just, nobody really knew the extent of the heart disease. So these are just what we see in terms of heart disease. So just as I said, those first three are linked, and then the other three in the bottom that I just mentioned. Okay. And just showing you that those top three really are eventually, it's just different ways of going into heart failure. So what are the symptoms of heart failure that we can see in sickle cell patients? I find that the most common one that I tend to see is exercise intolerance. Okay. Their ability to tolerate exercise can be diminished. Now, that is a tough one. Okay. Because in general, these are not patients who, many of them are already compromised in terms of how much exercise they can do, right? Because they're chronically anemic. So, how do I know this is heart failure? How do I know it's just because of the anemia? That's why we like to that's why I love our center because we form a relationship with them over time. So because you have a relationship with that patient, they see you regularly over time, a dramatic change in functionality over a short period of time is not what we expect, right? So if we see that drastic change, we're suspecting that there may be something more going on. Okay. So they can get short of breath. They get tired. I know you're going to say all of this they have because they have anemic, but again, we're looking for a significant change from their baseline. Like if you ask, what's your baseline? What's your baseline? They'll tell you where their baseline is. So a dramatic change from the baseline, we suspect that some of this stuff may be happening. And then we can see signs that go with heart failure. These signs that I have listed here are not specific only to sickle cell patients or even heart failure patients, but certainly they go with it. Like if they start swelling in their legs, the liver gets too big, it's just evidence of too much fluid in their body will go with it. And there's some lab tests that we can do, like N-terminal pro-BNP, that would really kind of like let us know, okay, if this is more of a heart failure picture or is this more of just the chronic anemia. So surprisingly enough, heart failure admissions are not very frequent in patients with sickle cell disease. But we know that that incidence is increasing. And the reason is because they're living longer. So not only are they dealing with sickle cell now, they're also dealing with what your typical older person deals with. Now, it might be seeing it a little younger in them, but you're not seeing it when they're 20s. But maybe in their 40s, they suddenly have all the usual things we will be concerned about in an older population. Okay. Um, so some of this stuff is again is related to if they tend to have higher blood pressure, the older they get, the more anemic they are, the more kidney disease they have, it would all usually those are precursors or markers of people who are more at risk for developing the heart failure. And we just show it, and I'm not going to belabor this. There are things that we measure on a regular basis in the echocardiograms of these patients to let us know who is at risk. Are we doing okay on time, Dr. Austin?
We end at 8:30, well, 7:30, so we have about 25 minutes. And I just wanted to just make sure everyone knew that they could ask questions. Genesis has been able to join us now, so and I really would love for her to just give her introduction because she does also live with heart issues. So if you don't mind, if
Yes.
Genesis could speak now.
Absolutely. I think I kind of gave you most of what I was going to present. So absolutely, I'm happy to just kind of do questions and discussions, open discussions.
Yes, thank you for your presentation. It was very, very informal, and I appreciate you being here, Dr. Sibonia. I'm sorry if I mispronounced your name. But like Dr. Austin was saying, I do have heart issues, and I have myocarditis, and I am still trying to figure out how to, I guess, heal my heart. They say that my the left side of my ventricle is um, a little bit bigger than my right, and so it's overworking a little bit than it should. So I'm having to be on steroids as a result, and that's not really a very fits all for trying to get I guess overall heart treatment. So that is kind of where I am, but it is good that I don't have any other issues in regards to my heart. Um, but yes, if you guys have any questions about the presentation or just what you guys have any thoughts, please come off mute or and let's have a discussion.
Genesis, did you develop the heart issue before or post transplant?
Yes, so this was a complication post transplant. Um, it was something that I went in, I thought I was actually just having pain, and they told me that my troponin levels were elevated and that I was having a heart attack. And I thought that was weird because I never had heart issues. And the end result was that they told me I had myocarditis and that my troponin levels were off the chart. So yeah.
Well, everyone's being shy, but please cut me off. My first question is, Dr. Chiadika, is there prevention or is there something we can do or a top 3 or top 5 thing that we can recommend to increase heart healthiness or heart health amongst our warriors and even some symptomatic trait warriors? You're muted.
Most of my recommendations are almost similar, really. When we start talking about prevention really has the same baseline, regardless of whether somebody has an underlying condition or there is a sickle cell patient or not. But with a sickle cell patient, the way I always present it is, I say, because we have this chronic condition that's always there anyway. So we want to be even stricter because the things that would normally happen to other people will be multiplied in a sickle cell patient. So what are those? And we know that a heart healthy diet, people who adhere to that, they do better. They live longer. So we want to eat a diet that's less in saturated fats. What are saturated fats? I would say things red meat, cheese. I always say battered, buttered. Less saturated fat diet will be better for us. It's heart healthy, and adhere more to a diet that's rich in plants and healthy proteins, and some carbohydrates, but that should not be the majority. If it's possible, more plant-based. Not that it has to be all plant-based, but lean meats are okay as well. Um, and so we know patients on those kind of lifestyle, they do better over time. They also are able to keep the weight down because we know obesity is a very complex thing because obesity, it links to diabetes. It links to heart disease. Diabetes leads to heart disease. Obesity leads to hypertension. Hypertension leads to heart disease. So obesity can affect the heart in so many ways, what it does to other conditions that also affect the heart, and then what it does directly to the heart. So keeping the weight healthy is always a good idea. Exercise, okay? I mean, we sing this song all the time, but we were talking to one of my patients today. I was like, we all like to hear it though, because when we hear it, it's good to keep hearing it. It helps us to do it. So exercise, we want to be exercising on a regular basis. Okay. At least the recommendation is the goal, is what I like to say. At least 45 minutes most days of the week. Okay. Moderate intensity exercise. Moderate is subjective. For some people, that's walking briskly. For some people, it's jogging, whatever it is. With moderate exercise, aerobics, dancing, whatever it is, doing exercise regularly. We know these things that we just talked about help us to prevent heart disease. But beyond that, it is important to know our risk. And we don't know our risk unless we check it. Because most of the risk factors are silent. You feel great until suddenly there's a stroke or there's a heart problem. So that's why it's important to do regular doctor checkups or to get the blood pressure checked and to get the cholesterol numbers and be familiar with what those different lipid values should be. Because it's not just cholesterol. If somebody's just checking your cholesterol, they're not doing a good job. They should be checking a panel where there's good cholesterol, bad cholesterol, total cholesterol, the triglycerides, which are like the fats in the blood, and understanding what those targets should be so you know what you're working towards. So you know maybe medication needs to be started so you can be on the medication to control that risk factor. I'll stop there.
I have a question. Um, so is there any type of, I guess, testing or anything? Because we were talking about prevention, but like they looked at my troponin levels for like my heart, but like, is there any type of testing that we can look for in regards to sickle cell for just the overall heart health that we can kind of understand and be like, okay, this is the marker, these are the things that you need to look for just to be sure about your heart for in regards to sickle cell?
Great question. Yes. So in sickle cell patients, we do regular echocardiograms on them. That is ultrasound of the heart. I didn't get to it in my presentation, but it's good we're talking about it. Echocardiogram, that's ultrasound of the heart, where we look at the structure of the heart, we measure the size of the heart, we look at how it's pumping, how it's relaxing, we measure the pressures within the heart. And that is actually something that's part of our routine care now, where they should be getting, regardless of how they feel, every few years, that should be monitored. There are numbers that we need to be monitoring. Maybe we need to put them on certain medicines. Maybe we need to put them on a water pill. Maybe we need to refer them to a specialist. That's how we know. We don't wait till they start feeling bad. We check with the echocardiogram. We always like to get a baseline electrocardiogram. That's more of like the regular EKG, like the wires that you would get during any doctor's office. And that's more of a baseline. You really can't screen them for heart disease with the EKG, but it's good to have a baseline since we know there's a lot going on with the heart. So if there's a change, it's good to have a reference. Um, at times, I will put my sickle cell patients on a treadmill and see how much exercise they can do. And that's important because it's good to check them out while they're exercising. Because some of the problems they can have, you don't pick them up when they're not doing anything. But when they're exercising, we pick it up. And so we can be proactive. Um, there are some blood tests. I mentioned it briefly earlier that we do N-terminal pro-BNP. It's just a blood test. And if it's elevated in somebody who's maybe a little short of breath, that can indicate heart failure. So there are times when we do check that as a marker. Um, those are the most common ones that I think we do, just kind of checking on the status of the heart.
Can I follow up Genesis' question? Is there, I guess, a higher prevalence amongst the genotypes of SS or E or C or others, or are these recommendations or goals for all the genotypes across the spectrum?
So we kind of treat everybody the same, but the SS has more prevalence of heart disease than the others. But we see it in really people who have the clinical syndrome of sickle cell disease. We do see it.
And what about when does it manifest? I know I'm not asking you to predict the future, but my child is born with sickle cell disease. Do we automatically start, working with the heart, or are these tests automatically done, or do symptoms have to present first?
So hopefully people are not waiting for symptoms. That's hopefully I'm bringing hopefully I'm saying that across today that we don't wait till people have symptoms. So I know about the adult world because I'm an adult cardiologist. I don't know as much what the guidelines the pediatric people follow. There are some clinical trials going on right now where they're trying to answer some of these questions on what exactly how quickly how should we be monitoring them and stuff like that. But I can tell you what I do on the adult side. So 18 and over, uh, all, all comers, we always get a baseline of all the tests I mentioned, the echo, the EKG. And let's say we do it and everything looks completely normal. They'll probably get another one. We follow the guidelines that say we should probably repeat it every 3 years or so, 2 to 3 years, comparing the values, the dimensions of the heart, the pressures within the heart. And if we see a tendency where things are going up, then we will now do more invasive testing to see, because sometimes the non-invasive test, the echo can say something is wrong, but it's not really wrong. Okay, so there's another level of testing, something more like a right heart cath, something more invasive where we actually go into the heart and measure the actual pressures within the heart. That will be indicated in that situation. But if we pick something up, then that moves things along faster as well.
Okay, so Ms. Moore, Emion, Ms. Carter, Ms. Kirby, anybody have any questions or comments?
I'm just kind of taking everything in because with my son that had SS, um, even even in his 30s, he really didn't have any cardiac issues. Even before surgery, prior to his death, his heart seemed to be the better organ, and so I'm not sure, why that was.
Yeah, so everything we're talking about is not absolute. So let me give you an example. There's a lot of millions and millions, almost 90% of people are going to have high blood pressure. 90% of everybody is going to
Right.
have high blood pressure by the time we get to about 80. Okay. But not everybody with high blood pressure has a stroke or has heart failure. Okay. So what we're talking about is not absolute, like everybody's going to develop heart disease. Everybody's going to develop anything. We look at proportion. What's the proportion of people who have the condition? So we want to catch the ones who are going to have the condition. So I'm gonna answer your question that way. I think that probably is what the situation is here. But also, what we have found is that people sometimes will have the heart disease, but it just wasn't diagnosed.
Okay. Okay. And then I know you said you basically deal with adults versus children. So is this something that would routinely be checked um in like an annual exam for someone with sickle cell?
So they will, if they're going to, it depends on, it depends on where they're being followed. I can only speak for what we do in our comprehensive sickle cell center.
Mhm.
Um, in our center, they get screened on a regular basis for heart disease. Okay. Like I said, if we do a baseline study and if everything looks normal, every 3 years or so, they'll probably get an echocardiogram. That's our practice. And we follow that over time. If they have symptoms, anything new going on with them, we'll move everything faster and check it out.
Okay. And you are in a comprehensive center. Um, and so are you guys what is your position as a doctor? Are you a
I'm a cardiologist, a heart
cardiologist?
doctor.
Okay, and so do you work with the hematologist or like primary care doctors or a little bit of all of them?
Well, I work with every doctor who sends me a patient. So I will be like a consultant. Now,
Okay,
for the sickles, because this is an area of interest of mine, I do collaborate with the hematologists, the sickle cell doctors. So whenever there's a question of heart related, those patients will be referred to my clinic, and I do follow those patients over time, just as they are following the patients.
okay. Thank you.
Absolutely.
Is cardiology or is cardiology for sickle cell patients common? Like, is that a common specialty or a practice that is attractive to med students?
I don't think there's a lot of people who specialize in
Yeah,
cardiology.
yeah,
Um, Cardiac related illnesses in sickle cell patients. There's not a lot of people. There are, it's
yeah,
just not many.
yeah. I know that even with in Houston, we just lost to retirement Dr. Foote. So a lot of adult patients uh, are now going over to Dr. Idowu because the that's one adult hematologist that's now gone and needing to be replaced. Um, and I mean my training is in public health, so we have been warned for years that primary care physicians are going to be a lost art at some point. But I also know there's not enough hematologists, and there's certainly not enough hematologists that are to sickle cell. And now we need these cardiac, specialists that specialize in sickle cell also. Um, we have a thousand leg table. That's the way I like to describe the world that is sickle cell and sickle cell trait. We are in trait space. And I'll just segue into one more question. Oh, Renee has a question. Go ahead, please unmute and ask your question.
Hello, Doctor. Is it Chiadika?
Yes.
What's the difference between pulmonology and cardiology? Because I know two of my friends are being followed by a pulmonologist.
Yeah. So a pulmonologist is a lung specialist, and then the cardiologist is the heart specialist. And because a lot of conditions of the lungs overlap with the heart and the heart overlaps with the lungs, you might get,
Have both.
yeah, we
Oh,
kind of
okay.
work
Okay.
together,
Makes
but
sense.
it's two different organ systems.
I'm going to ask a question, but you guys are certainly welcome to jump in. I saw your presentation for Emory, and I know you spoke about oxidative stress. Oxidative stress is something that comes up a bit in the trait world when it comes to exertion. Those athletes are experiencing oxidative stress when they end up collapsing and all of that. Um, what is your position on because like our founder, Devard, is an identical twin. He lost his identical twin brother to exertional sickling. That's what his death certificate says. It says high, dehydration and exhaustion complicated by sickle cell trait, because we know sickle cell trait does not have a cause of death. But that oxidative stress, I've heard of some people trying to treat it with L-glutamine, the kind that you get from GNC. Um, and there's even been some discussions of using Indari. But how would you, the cardiologist, would you recommend to young athletes with sickle cell trait as prevention, as things to look out for from the cardiology perspective?
Mhm. So as it is right now, there's no clear guidelines um, guiding us because guidelines will be based on evidence-based medicine. So we don't have that evidence-based medicine to back us up in terms of doing anything different from the average person if they have sickle cell trait. But yet, over the years, I think many of us can attest to the fact that we have anecdotal incidences where somebody has a trait and they have some symptoms when they get to a certain thresholds. It's not every one of them, but there are people who are like that. So, um, no, I don't have any evidence-based guidelines to give, except to say, obviously, a patient, somebody who's carrying a trait, if they're having some of the symptoms that are typical to sickle cell disease, they need to be not just go see a, down the road kind of doctor, you need to be in one of these like specialized sickle cell centers where they will have access to like on the curb, like really, up to date, scientifically backed treatment or way of thinking about the condition so that they can guide, in a better way through that. Because I barely see anybody with a trait. Patients are sent to me because they have sickle cell disease, and the specialist is like, okay, check out their heart. Something's good. They short of breath. They have high blood. Check out their heart. So it's a difficult space because there's just, you know, and it's not because it doesn't mean there's nothing to it, but somebody has to be willing to put the money and the research and, into it. So maybe with time, we might learn more, but that's kind of where we are now.
Ms. Moore, your hand is raised.
Yes. So in regard to the oxygenated stress, um, can you mention a little bit more about that? Because I really do know that I have that. And it's just amazing that there's no research or no studies that are being done about that when it's starting to be such a prevalent conversation.
Are you talking about in people who carry the trait,
The
or you're talking about in in patients who have sickle cell disease?
the trait.
I mean, again, I can't give you information I don't have. We don't really know much about it, except again, cases, individual cases of people who will be like, listen, this is what I feel when I reach a certain threshold of exercise or stress or challenge. I hurt, okay? Or I'm short of breath, or I have chest pain, and all we find is that they have the trait. It's not a lot of people, but it exists. So we don't really know what that means. Are these people who would have, excuse me, are these people who would have had this condition even if they didn't have the trait? Well, you need to do the research to know that, right? Because sickle cell patients are not the only ones who are subject to oxidative stress. Okay, that can happen to anyone, really. If you put anybody who's not in shape or something, put them on a treadmill and run them too hard, they will go into crisis-like mode where the cells begin to be challenged and go ischemic. So what is how to tease that out? What part of it is the trait? What part of it is just what other things that maybe underlying conditions or whatever? That is a difficult thing to know since we don't have the science to back up we don't know.
Mm-hmm.
Well, when I win the lottery or Maybe, and I'm being so sarcastic, but really what we're talking about is funding. We need funding to be able to do the research that we need to do to either back up the anecdotal data or find the evidence to further move the needle. But we're going to do
Speaking
what
of
we're doing.
funding, sorry, go ahead.
No,
Speaking of funding, I have a follow-up question. Do you know much about GVHD of the heart?
Mm-mm.
They were proposing that I had GVHD of the heart due to just how my situation presented itself and not really being able to find anything else. My EKG was abnormal at first, but it leveled out, and then my echo was normal. So they just kind of chalked it up to GVHD of the heart. But they could only really rule it out by doing what is it, a biopsy of my heart, but they didn't do a biopsy because that's kind of a risk. I didn't really want to do a biopsy of my heart, but so they just have been monitoring it, and my levels have gone down with the for my troponin levels. Thankfully, the Jacophy.
Mm-hmm. Yeah, I just Googled it. I don't know the acronym, but I know the when it's spelled out. So you're talking about graft versus host
Yeah,
disease,
yeah.
because
Sorry.
you've had a transplant. I missed
Yes,
it. What kind of transplant did you have?
I had a half match transplant, haploid identical transplant, or bone marrow
Bone
transplant.
marrow transplant to treat
Yes,
the sickle cell disease.
yes,
Okay.
yes.
So, I mean, graft versus host, I don't know about it because that's just not my area, but I know enough that just general medical information. That's when the cells that were transplanted in you, it looks like it's trying to fight your own intrinsic cells. And that's just
Mm-hmm,
anytime you have one of these bone marrow transplantations for any bone marrow stem cell transplantation for any disease condition, there are some risk, right, that can develop, and
mm-hmm,
that would be one of the ones that I know they're usually concerned about. So it
mm-hmm.
sounds like that may be what they're concerned about here.
Yeah.
Way out of my, playground,
Mm-hmm,
but hey, it's something that you can see after a transplantation, and so maybe that's what's
mm-hmm.
happening
Yeah.
too. I mean, that sounds difficult. That's
Yeah.
another journey, Yeah.
It is. It's been a journey. But yes.
Mhm.
Thank you. It is 7:30. So we are going to go ahead and wrap it up. Thank you so much, Dr. Chiquita. Oh, I'm sorry, I'm butchering your name, but
Chiadika.
Chiadika, thank you so much for your excellent presentation and knowledge. We have learned so much about heart health in regards to sickle cell, and we had a great discussion. Yeah, it's been great. Do you have any other remarks, Dr. Austin, before I close it out?
I do not, but just thank you. Thank you so much. I really appreciate it. And
Thanks
thank
for having
everyone for
me.
being here.
Thank you.
Yes. All right. Well, we'll see you guys next month.
Have a good
All right.
evening. Thank
You
you.
too. All right.